Good evening, Dr. Phil here. Today we'll be discussing on amiodarone. Amiodarone is an iodine-rich benzofuran derivative with a chemical formula of C25H29I2NO3. Formulation in the tablet form is 100 to 200 mg. In solution, it is 150 mg per ampule. Mechanism of action. Regarding pathophysiology of arrhythmias, kindly refer to the video discussing that topic for further details. Amiodarone demonstrates class 1 activity, which is sodium channel blockade, class 2 activity, which is beta-adrenergic receptor blockade, class 3 activity, which is potassium channel blockade, class 4 activity, which is calcium channel blockade, and competitive inhibitory actions at alpha adrenoceptors. Overall effects of amiodarone. In the atria and ventricles, there is increased action potential duration, increased refractory period, prolongation of repolarization, and slowing of AV node and ventricular conduction velocity. There is minimal myocardial depression. There are anti-anginal effects from its alpha and beta adrenoceptor blocking properties and calcium channel blocking effects in the coronary vessels. Onset of action via IV route is 20 to 30 minutes. Duration of action via IV route is variable and lasts 2 weeks to months. For other effects, kindly refer to the section discussing on the adverse effects of amiodarone. Pharmacokinetics. Absorption via oral route is poor. Bioavailability is 50 to 70%. Therefore, 600 mg oral amiodarone is equivalent to 300 mg IV amiodarone. Peak serum time is 3 to 7 hours. Onset time via oral route for the initial response is 2 days to 3 weeks. For the peak response, it's 1 week to 5 months. Duration of action is variable, up to 50 days after discontinuation of therapy. Therapeutic range is 0.8 to 2.8 micrograms per ml, and toxicity range is more than 2 to 2.5 micrograms per ml. Distribution. Volume of distribution is 2 to 70 liters per kg. Protein bound more than 95%. Accumulation. Amiodarone is highly lipid-soluble. Amiodarone and its metabolites accumulates to a considerable extent in muscle, fat, liver, lungs, and skin. Metabolism of amiodarone is in the liver by the cytochrome P450 enzyme system, CYP2C8 and CYP3A3 and 3A4 isozymes. There is enterohepatic recirculation. Amiodarone inhibits CYP2C9, CYP2D6, and CYP3A3 and 3A4. The active metabolite is desmethylamiodarone, DEA. This compound has some antiarrhythmic activity. Excretion is via the feces and the urine. Elimination half-life is 20 to 100 days for the parent drug and 61 days for DEA. This prolonged elimination half-life is the result of the drug's slow release from lipid-rich tissue. Amiodarone is not dialysable by hemodialysis or peritoneal dialysis. Clinical indications for amiodarone. Amiodarone is used in the treatment of supraventricular arrhythmias such as atrial fibrillation, atrial flutter, and supraventricular tachycardia, and in the treatment of ventricular arrhythmias such as ventricular tachycardia, ventricular fibrillation, and Wolff-Parkinson-White syndrome. Regarding AF, amiodarone is an effective agent for the acute rate control in critically ill patients with atrial fibrillation. It causes less cardiac depression than diltiazem and is preferred for the rate control in patients with systolic heart failure. Due to toxic effects associated with long-term use, amiodarone is usually reserved for cases of AF that are refractory to rate control with other agents. Amiodarone is also capable of converting AF to a sinus rhythm. For persistent AF present for more than 1 year, this conversion is uncommon. For recent onset AF, success rate for conversion is 55 to 95% when a loading dose and continuous infusion are used, and the daily dose exceeds 1.5 grams. Regarding unanticipated cardioversion, this can be problematic if patients are not adequately anticoagulated due to risk of thromboembolism. For tachycardia with a pulse, amiodarone may be considered in unstable patients with shock, syncope, myocardial ischemia, or heart failure when synchronized DC shock up to 3 attempts is unsuccessful in treating the tachyarrhythmia. The dose for amiodarone is 300 mg IV over 10 to 20 minutes and repeat shock, followed by amiodarone 900 mg over 24 hours. Amiodarone is also used in the treatment of ventricular tachycardia when the patient is stable. The dose is 300 mg IV over 20 to 60 minutes, followed by 900 mg over 24 hours. Amiodarone is also used in the treatment of irregular narrow complex tachycardia when the patient is stable, if there is evidence of heart failure. Anticoagulate if the duration is more than 48 hours. During cardiac arrest, amiodarone is used after the third shock for VF and pulseless VT unresponsive to defibrillation, CPR, and adrenaline. The dose is via IV or IO route. The first dose is 300 mg bolus, the second dose is 150 mg bolus. Amiodarone treatment can be stopped abruptly when the cause of the arrhythmia has resolved. Dosage for adults. Regarding tachycardia with a pulse, the dose has been discussed in the previous section. The loading dose is typically 5 mg per kg or 300 mg in the typical adult, and the maintenance dose is typically 15 mg per kg over 24 hours, which amounts to 900 mg in the typical adult. After 24 hours, amiodarone can be continued to be administered. For example, 0.5 mg per minute for 2 to 3 weeks regardless of patient age, renal function, or ventricular function, 600 mg IV daily for 7 days, followed by 400 mg IV daily for 7 days, then 200 mg IV daily. In patients requiring long-term amiodarone, intravenous dosing should be switched to oral dosing. If there is less than 1 week of IV infusion, the oral dose is 800 to 1.6 grams per day oral. If there is 1 to 3 weeks of IV infusion, the dose is 600 to 800 mg per day oral. If there is more than 3 weeks of IV infusion, the dose is 400 mg per day oral. Adjust according to response. The dose for VT or VF pulseless arrest. The first bolus is 300 mg via IV or IO route. If there is no conversion, the next dose is 150 mg via IV or IO route. After conversion, the first infusion should be 360 mg IV over 6 hours or 1 mg per minute, followed by the second infusion 540 mg IV over 18 hours at 0.5 mg per minute. The oral dose is 200 mg TDS for 1 week, followed by 200 mg BD for another week, followed by 200 mg OD thereafter. Dosage below 300 mg per day are associated with a reduced incidence of pulmonary adverse effects. The necessity of an oral loading dose for amiodarone. An oral loading dose regimen is necessary even when the patient has been adequately loaded intravenously, because amiodarone has a large volume of distribution and a long half-life. High initial plasma levels quickly fall as the drug distributes and binds to peripheral lipophilic tissues. The initial IV and oral therapy should be overlapped for 16 to 24 hours. Caveats. Before initiating amiodarone treatment, correct hypokalemia, hypomagnesemia, and hypocalcemia. Administration of IV amiodarone. For conventional amiodarone, dilute only with dextrose 5%. Administer in glass or polyolefin bottles for infusion lasting more than 2 hours. There is no need for protection from light during administration. Be wary of IV incompatibilities such as heparin, aminophylline, ampicillin sulbactam, digoxin, furosemide, etc. Nexterone is unlike conventional amiodarone. It does not have the original co-solvents polysorbate 80 and benzyl alcohol. Nexterone does not have the many administration limitations of conventional amiodarone regarding compatibility and stability with plastics and ionic infusion fluids. Nexterone may be diluted with either dextrose 5% or normal saline and may be administered in PVC, polyolefin, or glass containers. Regarding the concentration of amiodarone, the range is 1 to 6 mg per ml. Concentrations of more than 2 mg per ml is associated with venous irritation and should be administered via central venous catheter with an inline filter by a volumetric infusion pump. Amiodarone is stored at room temperature. Protect from light and excessive heat. Dosages vary. Please follow your own institution's guidelines. Total dose should not exceed 2.2 grams in 24 hours. If via IV route, administer via central line with continuous cardiac monitoring. Do not administer amiodarone via a peripheral vein due to risk of thrombophlebitis. A volumetric pump should be used as the droplet size of amiodarone may decrease. Adjust dosage based on adverse reaction and therapeutic response. Contraindications for amiodarone includes bradycardia due to risk of asystole, AV block unless pacemaker is fitted, polymorphic VT associated with a prolonged QT interval because this may worsen the patient's condition, severe sinus node dysfunction, cardiogenic shock, hypersensitivity, iodine sensitivity as amiodarone contains iodine, pregnancy. Fetal exposure to amiodarone may increase the risk of cardiac, thyroid, neurodevelopmental, neurological and growth defects, neonatal bradycardia, QT prolongation, and periodic ventricular extrasystoles, neonatal hypothyroidism, fetal growth restriction, and premature birth. Breastfeeding is another contraindication. Adverse effects of amiodarone. These adverse effects will affect most patients if amiodarone was given long enough. Most of these adverse effects are reversible if amiodarone is stopped. Cardiac adverse effects. Bradycardia or sinus arrest occurs in 5%, especially when large doses are given rapidly. The patient may be unresponsive to atropine. AV block occurs in 5% and SA node dysfunction occurs in 1 to 3%. Hypotension occurs in 15% of patients, especially when large doses are given rapidly. IV amiodarone is available in 2 formulations. Conventional amiodarone contains polysorbate 80, which is a vasoactive solvent that promotes hypotension, while nexterone contains captisol, which has no vasoactive effects. Prolonged QT interval may occur. However, amiodarone has low arrhythmic potential. Acute MI may occur. Pulmonary adverse effects includes pneumonitis, fibrosis, pleuritis, ARDS, bronchiolitis obliterans organizing pneumonia, eosinophilic pneumonia, and pulmonary alveolar hemorrhage. Incidence is 10% at 3 years. Mortality rate is 10%. Pulmonary complications may be reversed if amiodarone is stopped early. Exacerbating factors includes increased FiO2. Neurological or muscular adverse effects includes peripheral neuropathy, myopathy, dizziness, headache, abnormal gait or ataxia, fatigue, impaired memory, involuntary movements, sleep disturbances, visual disturbances, optic neuritis, pseudotumor cerebri, Parkinsonian symptoms, rhabdomyolysis, and delirium. Ophthalmic adverse effects includes corneal microdeposits, which causes halos and mild blurring of vision. This is usually reversible upon discontinuation of amiodarone. Ophthalmic examination is recommended annually for patients on long-term amiodarone. Hyperthyroidism occurs in 0.9% and hypothyroidism occurs in 6% of patients. Amiodarone is an iodinated compound and it prevents the peripheral conversion of T4 to T3. Amiodarone confounds thyroid function tests. Amiodarone may cause thyroid nodules and thyroid cancer. Thyroid adverse effects is reversible upon discontinuation of amiodarone. Amiodarone may cause metallic taste, intestinal upset, constipation, and anorexia. It may also cause hepatitis in 3 to 20% of patients and cirrhosis in less than 3% of patients. The patient may present with deranged LFTs and jaundice. Pancreatitis may be caused by amiodarone. Amiodarone may cause renal impairment and acute renal failure. Amiodarone may cause photosensitivity, slate gray skin, and toxic epidermal necrolysis. Other adverse effects include phlebitis of peripheral veins, anaphylaxis and urticaria, SIADH, hemolytic anemia, aplastic anemia, pancytopenia, neutropenia, thrombocytopenia, agranulocytosis, granuloma, and lupus-like syndrome. epididymitis, and impotence. Drug interactions. Amiodarone is highly protein-bound, more than 95%, and may increase the effects of other highly protein-bound drugs by displacing them from their protein binding sites, potentially increasing toxicity of drugs such as phenytoin, warfarin, digoxin, and cyclosporine. Their doses should be adjusted when co-administered with amiodarone. Amiodarone also inhibits digoxin and warfarin metabolism, increasing their effects. Regarding drugs that slow AV conduction, caution should be exercised when amiodarone is used with these drugs such as beta blockers and verapamil due to increased risk of bradycardia, AV block, and myocardial depression. Regarding drugs that prolong the QT interval, amiodarone should not be given with these drugs such as phenothiazines, TCAs, thiazides, diltiazem, verapamil, sotalol, and class 1A antiarrhythmics for fear of precipitating torsade de pointes. Amiodarone may increase the incidence of myopathy when co-administered with simvastatin of a dosage of more than 20 mg per day. Other class 3 antiarrhythmics. Dronedarone. This is a non-iodinated antiarrhythmic agent structurally related to amiodarone and is used for long-term treatment of atrial fibrillation. It presents as oral tablets of 400 mg. Those adjustments are not necessary in renal or mild to moderate hepatic impairment. Effects. It has properties belonging to all 4 Vaughan-Williams antiarrhythmic classes, which include sodium channel blockade, beta-adrenoceptor blockade, potassium and calcium channel blockade. It prolongs cardiac repolarization and has negative inotropic effects. Pharmacokinetics. Bioavailability is 4% without food and 15% with high-fat meal. Peak plasma time is 3 to 6 hours, including major active metabolite, and at steady state, 2.6 to 4.5 hours. Protein bound is more than 98%. Volume of distribution is 1,400 liters at steady state. Metabolism is in the liver by CYP3A4. Metabolic pathways involves N-deputylation to form active N-deputylyl metabolite, oxidative deamination to form inactive propanoic acid metabolite, direct oxidation, and metabolites undergo further metabolism to yield over 30 uncharacterized metabolites. The active metabolite N-deputylyl metabolite exhibits pharmacodynamic activity, which is 1/10 to 1/3 as potent as dronedarone. Elimination half-life is 13 to 19 hours. Clearance is 130 to 150 liters per hour. Excretion via the urine is 6% and via the feces 84%. Contraindications for dronedarone includes hypersensitivity, heart failure, and permanent AF. There is increased risk of death, stroke, and heart failure in patients with decompensated heart failure or permanent AF. Dronedarone is not for use in patients with symptomatic decompensated heart failure occurring within 4 weeks, requiring hospitalization, or NYHA class 3 or 4 symptoms. Dronedarone offers no benefit in permanent AF. Other contraindications include 2nd to 3rd degree heart block or sick sinus syndrome, bradycardia of less than 50 beats per minute, prolonged QTC interval or PI interval more than 280 milliseconds, hypokalemia, severe hepatic impairment, concomitant strong CYP3A4 inhibitors such as grapefruit juice, itraconazole, clarithromycin, and erythromycin. Co-administration with drugs that prolong the QT interval may cause torsade de pointes such as phenothiazines, TCAs, macrolide antibiotics, class 1 and class 3 antiarrhythmic agents, etc. Pregnancy and lactation is another contraindication. Adverse effects of dronedarone includes QTC prolongation, early increase in serum creatinine, diarrhea, asthenia, nausea, skin reactions, abdominal pain, bradycardia, vomiting, dyspepsia, increased risk of stroke, and other post-marketing reports such as heart failure, hepatic injury, cardiac failure, pulmonary fibrosis, interstitial lung disease, anaphylaxis, vasculitis, atrial flutter, photosensitivity, etc. Drug interactions with CYP3A4 inhibitors includes increased effects of dronedarone, drugs that prolong QT interval there may be increased risk of toxicity points. Warfarin. Post-marketing cases of increased INR have been reported with warfarin-treated patients initiated on Dronedarone. Potassium depleting diuretics increase the risk of electrolyte imbalances, which potentiates the toxicity of Dronedarone. Ibutilide. This drug is used in the treatment of AF and comes in IV solution of 0.1 mg per ml. Dose adjustment is not necessary for hepatic or renal impairment. It is a class 3 antiarrhythmic which markedly prolongs action potential and repolarization and increases both atrial and ventricular refractoriness. Onset of action is 90 minutes following infusion and duration of action is 24 hours. Half-life is 2 to 12 hours, protein bound 40%, volume of distribution 11 liters per kg, metabolism is in the liver, the hydroxy derivative is active, excretion is 82% in the urine and 20% in the feces. Ibutilide is contraindicated in prolonged QT, hypersensitivity, lactation, and pregnancy. Caution in electrolyte abnormalities such as hypokalemia and hypomagnesemia, which should be corrected prior to Ibutilide administration. Bradycardia, congestive heart failure, history of polymorphic VT after antiarrhythmic therapy, proarrhythmic events, recent MI, patients with atrial fibrillation lasting more than 2 to 3 days, liver disease, and other antiarrhythmic agents. Adverse effects include headache, bradycardia, hypertension, hypotension, palpitations, QTc prolongation, nausea, heart failure, skin reactions, renal failure, ventricular tachycardia, syncope, heart block, and potentially lethal arrhythmias such as toxicity points. Continuous ECG monitoring should be present during treatment. Have all materials at hand to handle potentially lethal arrhythmias for at least 4 to 6 hours after Ibutilide administration. Dofetilide. This drug is used in the treatment of AF. It comes in oral capsules of 125 mcg, 250 mcg, or 500 mcg. It is a new class 3 antiarrhythmic that selectively inhibits inward potassium currents, prolonging repolarization, effective refractory period, and QT interval. Onset is 2 hours, duration of action is 4 hours. Bioavailability is more than 90%, peak plasma time is 2 to 3 hours, protein bound is 60 to 70%. Volume of distribution is 3 to 4 liters per kg. It is metabolized in the liver by CYP3A4 to inactive metabolites. Half-life is 10 hours, 80% is excreted in the urine, dose adjustment is necessary in renal impairment, less than 10% is excreted in the feces. Dofetilide is contraindicated in hypersensitivity, prolonged QT, concomitant use of cation transport system inhibitors, severe renal impairment, pregnancy and lactation. Caution in electrolyte abnormalities, AV block, bradycardia, patients taking potassium depleting diuretics, moderate QT prolongation, proarrhythmic events, liver or renal disease, co-administration of drugs that prolong QT interval and other antiarrhythmic agents, and grapefruit juice, which may increase Dofetilide levels. During administration, the patient should be hospitalized for minimum of 3 days during initiation or reinitiation to minimize the risk of induced arrhythmia. Facility must provide creatinine clearance calculations, continuous ECG monitoring, and resuscitation for at least 3 days when initiating or restarting therapy. Adverse effects include headache, chest pain, dizziness, insomnia, respiratory tract infection, dyspnea, rash, flu-like syndrome, back pain, VT, toxicity points, nausea and diarrhea. Bretylium. This is a quaternary ammonium compound that prevents noradrenaline uptake into sympathetic nerve endings. It prolongs action potential duration and refractory period and has no effect on automaticity. It was used as second-line therapy to lidocaine for resistant life-threatening VT. Major side effect is hypotension due to its anti-adrenergic actions. It is no longer available in the UK. The use of Bretylium has been forgotten due to shortages in supplies of the chemical substance, and the drug substance is difficult to manufacture. These are my references. Thank you.